Guys, welcome to Dr. Science. So today we are going to see why angiotensin receptor blockers are contraindicated in renal failure. In order to understand this, we have to understand the normal physiology of the kidney. So as you can see here we have the angiotensin 2 molecule, and whenever the angiotensin 2 is secreted, it will go to the efferent arteriole and bind to the angiotensin receptors. So as you can see here, angiotensin 2 will go and bind to the angiotensin receptors, and eventually this efferent arteriole will lead to vasoconstriction. Now what is going to happen if there is vasoconstriction of the efferent arteriole? So as you can see here, whenever there is efferent arteriole constriction, this will lead to increase in the renal plasma flow. And whenever there is increase in renal plasma flow, there is also increase in the hydrostatic pressure. And this increased hydrostatic pressure will cause increase in the GFR, or the glomerular filtration rate. So in summary, whenever there is vasoconstriction at the efferent arteriole, there is increased renal plasma flow, which was increasing the hydrostatic pressure and thus increasing the glomerular filtration rate, or the GFR. In simple words, we can say that the kidneys are well hydrated or well perfused in case of efferent arteriolar constriction. Okay, now we have to understand what is happening in the renin angiotensin aldosterone system, or the RAS system. So as you can see here is our liver, and our liver is producing a compound known as your angiotensinogen. This angiotensinogen is converted into angiotensin 1 by an enzyme called as renin, and this enzyme is secreted by the kidneys. Eventually the angiotensin 1 will get converted into angiotensin 2, and this is by an enzyme called as your angiotensin converting enzyme, which is produced in the lungs. Okay, so finally the angiotensin 2, which causes efferent arteriole constriction, will go and bind to the angiotensin receptors, and hence there is vasoconstriction at the efferent arteriole. Now imagine we are going to give angiotensin receptor blockers or ACE inhibitors. In both of the cases, there will be decrease in the angiotensin 2, and this decrease in angiotensin 2 will lead to vasodilation. So now we have to understand what will happen if there is no angiotensin 2, or we have given angiotensin receptor blockers. Now imagine we gave angiotensin receptor blockers. So what will happen? There will be decrease in the angiotensin 2. Hence the efferent arteriole will eventually dilate, and this dilatation of the efferent arteriole, as you can see here, there is no more constriction and there is dilation. There is dilation of the efferent arteriole. Let's draw with different color here. So there is dilation of the efferent arteriole. Whenever there is dilation of the efferent arteriole, there is decrease in the renal plasma flow. Hence there will be decrease in the hydrostatic pressure. Hence there will be decrease in the glomerular filtration GFR, or the glomerular filtration rate. So in summary, whenever there is efferent arteriolar dilation, there is decrease in the renal plasma flow, hence there is decrease in the hydrostatic pressure, which will eventually decrease in the GFR, or the glomerular filtration rate. This decrease in the glomerular filtration rate means the kidneys are not getting hydrated, or we can say the kidneys are not well perfused. Now imagine a patient who is already having renal failure. The patient is having renal failure. On the top of that, there is no perfusion of the kidneys. If there is no perfusion of the kidneys, obviously the kidneys will die. There will be chronic renal failure. Okay, or there will be kidney injury. Okay. Now that's the reason we don't give angiotensin receptor blockers to patient with renal failure, because there will be decreased renal perfusion. I hope you understand this topic, guys. Thank you.